Welcome to the VTE Awareness podcast, where we break down essential clinical topics for busy healthcare professionals. I'm Charlie.
And I'm Feba. We are anticoagulation nurses, and today we are here to cover a vital aspect of patient care both in hospital and after discharge: venous thromboembolism, VTE, and what we need to know about the prevention, education, and escalation. So, Charlie, what is VTE?
VTE is a condition in which blood clots form in the veins. In the UK and worldwide, VTE is a leading cause of death and disability. Globally, up to 60% of blood clots occur within 90 days of hospital discharge. VTE can affect anyone regardless of age, gender or ethnicity. Therefore, VTE prevention is critical in maintaining patient safety, both when they are in hospital and on discharge. VTEs are preventable in many ways, but only if we are proactive. So, Feather, let's start simple. What is VTE?
VTE is a venous thromboembolism, which is an umbrella term for DVT and PE. DVT, deep vein thrombosis, is a blood clot that usually occurs in the deep veins of leg, and PE or pulmonary embolism is a clot that travels from the deep veins to the hearts and lungs and lodges there.
PE can be fatal if not recognised quickly. Blood clotting is an important process in the body, and it uses this to keep the body's balance in check. However, there are times when this process can go wrong, causing DVTs and PEs. Blood clots are more likely to develop when patients have high risk factors VTE or they are immobile, for example, when they're in hospital.
Exactly. Hospitalized patients are at higher risk due to immobility, surgery, acute illness, dehydration, cancer, pregnancy, and certain medications like oral contraceptives.
So, Feba, let's talk about deep vein thrombosis and the signs and symptoms to look out for. Key signs include unilateral leg swelling, pain or inflammation if a leg is hard to touch, and increased calf circumference.
And when it comes to pulmonary embolism, it is a life-threatening condition, and signs and symptoms include sudden shortness of breath, chest pain, tachycardia, low oxygen saturation, and collapse. Charlie, what should we do if a PE is suspected?
We should escalate the patient immediately using the new score system to assess your patient. But in some cases, patients don't demonstrate any signs and symptoms, and this can be very tricky.
Right. Now let's discuss what nurses must do in hospital settings.
Prevention starts at admission.
Absolutely. Nurses need to ensure that clinicians are completing the VTE risk assessments for each patient on admission to hospital within 14 hours, or if the patient has been in the emergency department for more than 12 hours. This should be reviewed if the patient's medical condition changes. Patients should be advised about the risk of VTE and measures to prevent this whilst in hospital. We should encourage patients to keep mobilizing if it is safe to do so, remain hydrated, take VTE prevention medication as prescribed, and wear VTE prevention devices should they be prescribed by the doctors.
An example of this is the IPC device. These devices are attached to patients as a VTE preventive measure if they are not able to have pharmaceutical and VTE preventative medications. Please ensure patients' legs are measured before placing the IPC or the anti-embolic stockings. This is to reduce skin damage, circulation impairment caused by the ill-fitting garments. Remove them at least once a shift just to check patients' skin and also to meet hygiene needs. The guidance for the use of the anti-embolic stockings may be changing in future. This is a result of new research around the risk versus benefits of these garments.
And document it. If the patient removes them, document and re-educate. Now let's talk about the anticoagulant medications. So, Charlie, which anticoagulation medication are most commonly used for the VTE prevention?
There are different dosing regimes available for VTE prevention and VTE treatment here at Harlow Hospital. The VTE preventative medication most commonly used is enoxaparin injections. At PAH, enoxaparin injections are the low molecular weight heparin of choice. However, there are other low molecular weight heparins available. As nurses, we should explain to patients that enoxaparin is a pork derivative and fondaparinux is available as an alternative within the trust. Other anticoagulation medications available include DOACs, direct oral anticoagulants. These include apixaban, edoxaban, rivaroxaban and dabigatran. These are oral anticoagulation medications with fixed dosing regimes. Not all patients fit the criteria for these medications. Patients' renal functions, body weight, medical history all need to be taken into consideration. There are also vitamin K antagonists. These include warfarin, synthrom and phenyidone.
Remember, these have no fixed doses like DOACs. It varies as per the INR result of patient. All patients should be referred to anticoagulation monitoring service during the discharge. And remember that every new patient on warfarin should be getting an anticoagulation record book.
Just like this one here.
It includes INR record, dosing schedule, safety information, and emergency contact details. We need to remember that every new warfarin patient must receive a yellow book, education on INR monitoring, drug and food interactions which are available on NHS website, bleeding precautions. So, what about VTE patient education, Charlie?
Education isn't optional. It's part of our duty of care to patients. On admission, we should be telling patients why they are at risk, what VTE is, the importance of mobility and remaining hydrated, and why they are receiving the injections or IPC or anti-embolic stockings. Please provide the VTE information leaflets and document it. The VTE information leaflets are now available on the Trust intranet.
And on discharge, educate them again about the signs of DVT and PE, when to seek urgent help, injection techniques if they are self-administering, safe storage and sharps disposal, length of the treatment. Give patients VTE leaflets and a yellow book if on warfarin. Remember to do a district nurse referral if patients are not self-administering the injections.
Let's talk documentation, because if it's not written down, it didn't happen.
Right, we must document about the education given to patients, including the leaflets provided and if the demonstration of injections if they are self-administering. Compliance with medication and VTE preventive measures should also be documented.
So, however, what if patients refuse prophylaxis? Because this does happen.
Yes, it does. So we must explore the reasons why it is being refused, re-educate them on the risk, inform the clinicians for any alternatives, and document the refusal and escalation clearly.
Refusal of anticoagulation medication increases the risk significantly, so escalation is essential.
So Charlie, what is the role of nurses in the management of patients on anticoagulation medications?
We should keep an eye on any missed doses, any sudden drop in HB, any unexplained bleeding or bruising demonstrated by the patients, sudden tachycardia and asymmetrical limbs. Early detection saves lives.
Remember, anticoagulation medications are high-risk medications, so risk of undertreatment causes thrombosis and risk of overtreatment can cause bleeding. So, we should have a clear communication and document the care which will help us keep the patient safe.
Thank you for listening to the VTE Awareness podcast today. For more information, please check the Thrombosis UK website. If you found this helpful, please share it with your colleagues.
So stay vigilant, stay proactive, and keep patients safe.
Watch out for another education podcast. Thank you.
Bye.